So welcome. Good afternoon, everyone. My name is Megan Piper, and I am a licensed clinical psychologist. I have a practice that is part of the General Internal Medicine Clinic at UW Health here in Madison. I'm also the research director, one of the research directors for our Center for Tobacco Research and Intervention here at the University of Wisconsin School of Medicine and Public Health. And the reason we're all here today, right, is the new Wisconsin Administrative Code, Chapter DHS 75. We're here to learn about how this came, a little bit about how it came into being, but more importantly, what are we going to do now that it's been in effect? And one of the things I want to emphasize is that this is actually more than just bureaucracy. This new chapter is really the culmination of hours and days of countless work to really help that health advocates have done to really help get tobacco dependence treatment, which is one of the key drivers of public health and public health equity, get them integrated into substance use treatment and recovery, where we have experts who are helping people change, who are expert at helping people change and get into recovery. And so the understanding of the code is that programs must have a written policy on how to assess and treat current tobacco use disorder. And we want to make sure that people understand why this is important, where this is coming from, and how important this is in terms of the health of the clients that you work with, and the public health in general, especially as we deal with health inequities. So welcome. And here's what we're going to try and cover in the next hour. We're going to talk about myths about smoking and substance use treatment. We're going to talk about some of the roadblocks, why this is relevant to integrating tobacco treatment into substance use settings. And then briefly, I'd like to cover a little bit about some of the key treatments in smoking cessation, why this group, everybody on the call, is so well suited to be providing this kind of intervention if you're not already doing so. So let's start with the myths. Factor myth. Now, before we get going on this, what I'd really like you to do is take out a piece of paper and write down either a fact or myth. Or if you don't want to write it down, put it in your phone or just say it out loud. People, I feel like, get this better when you commit one way or the other to whether this is a fact or myth. So first one, opioids kill more people than smoking. Fact or myth? Write it down or say it out loud. It's a myth. Opioids do not kill more people than smoking. Opioids are the most common drug for fatal overdoses, right? 75% of overdoses are related to opioids. But tobacco use is by far the leading preventable cause of death in the United States. And you can see here with the numbers, you see these are the numbers of deaths from 2016, and we added in the opioid and drug-induced deaths from 2020. And you can see that even if you doubled or tripled those numbers, you still would not get to the number of people who die from smoking-related diseases. We're talking about 500,000 people a year. That actually exceeds the death from COVID. And you know how much money and energy and public health campaigns have been put into effect related to COVID. Smoking has a similar toll, exacts a similar toll. All right, next factor myth. People with behavioral health conditions who smoke die up to 25 years prematurely. So go ahead, write it down, fact or myth? It's fact. In general, the life expectancy for people who smoke is approximately 10 years shorter than non-smokers. And I use this all the time when I work with smokers and they say, well, you got to die from something. And I say, well, sure, but do you want to lose 10 years of your life? And that usually is startling to them. But again, with people with behavioral health conditions, we're talking about 25 years of life. Why? Because smoking is linked to the 7 of the top 10 causes of death in the United States. It causes 30% of all cancers, 90% of all lung cancer, 30% of cardiovascular disease, and almost all of the COPD we see here in the United States. The reason that people with behavioral health conditions tend to die earlier, even earlier, is because these conditions are also associated with chronic stress, socioeconomic factors, less access to healthcare, fewer environmental protections. They're prey to predatory tobacco marketing policies and other issues that increase this risk for premature death. So really, the folks that you're working with in substance use treatment are not only more likely to die from smoking than they are from an overdose, but they're also going to lose a significant portion of their lives if they can't quit smoking. All right, next fact or myth. Nicotine causes cancer. Fact or myth? This is a myth. Nicotine does not cause cancer. There are more than 7,000 chemicals in a combustible cigarette, and 70 of those cause cancer, but nicotine isn't one of them. Nicotine is the chemical in tobacco that keeps you smoking. That's the piece that's addictive. So nicotine will keep you smoking, but the other 6,999 chemicals are the ones that are going to kill you. And the reason that nicotine is so effective is partially because it's a very effective chemical in and of itself, but it's also how fast it gets to your brain. As substance use treatment specialists, you know the speed with which the buzz hits, the speed with which the drug gets to the brain really impacts how addictive something is. When you smoke, it takes about 6 to 7 seconds for that nicotine to hit your brain and cause the dopamine release. Nicotine from patches and the gum and the mini lozenges, that gets to your brain more along the timeline of minutes, 15, 20 minutes. And so it replaces, the nicotine replacement products work for certain things, but they're non-addictive because they just don't get to your brain fast enough. This is a key issue, and it's been really hard for people to understand, especially with all of the media attention around e-cigarettes and how dangerous e-cigarettes are. But what I want to really emphasize is nicotine doesn't cause cancer. All of the other chemicals do. All right, next one, fact or myth. I can't repair the damage smoking's done to my body. I can't tell you how many times I've talked to smokers who've said, well, it's too late now. I've been smoking for 20, 30, 40 years. What's the point? So is that a fact or is that myth? That is a myth. In fact, you can repair the damage that smoking's done to your body. In fact, in 12 hours, the carbon monoxide in your blood drops back to normal. Within 48 hours, you're starting to actually regenerate some of those damaged nerve endings. Things start to taste better and smell better. Within a year, your risk of the excessive risk that smokers have of coronary heart disease is actually half that of a continuing smoker. And I forgot to hit, in 20 minutes, your blood pressure starts to drop. People that you work with that struggle with high blood pressure, that have to take medication, if they quit smoking, it's very possible their blood pressure comes under control and maybe they don't even need medication any longer. So your body can heal itself. Next one, people in substance use treatment want to quit smoking. Fact or myth? It's a fact. People in substance use treatment do want to quit smoking. In fact, there are numbers that range from a little less than half to almost 80% of people are interested in quitting or changing their tobacco use in some way. And actually, almost half of the people in one study found that substance use treatment participants made a quit attempt within the last year. All right, fact or myth, people with other substance use disorders can't quit smoking. They may want to, but they really can't. Fact or myth? That's another myth. People with substance use disorders can quit smoking. In fact, about 1 in 5 people do it. Now, people with substance use disorders may have more difficulty than those that aren't dealing with such challenges, and we're not 100% sure why. But here's some potential barriers to being successful. Maybe they weren't given evidence-based treatment. Maybe they weren't taught how to use their cigarette, or maybe they were actually taught as part of recovery to use their cigarettes as a treatment or a coping tool. I've talked to a lot of smokers who've been through recovery and said, well, I picked up my cigarette when I was in recovery from something else. And so that's another issue that we want to be able to deal with as substance use treatment providers, because again, you are invested in the health and well-being of your clients. And so this is another reason that helping them quit cigarettes is key, especially if cigarettes became part of their lives as part of their recovery. And then another one is sometimes they may be too scared about their sobriety to invest in smoking cessation. They're really worried that they'll go back to drinking if they give up cigarettes because it would just be too hard and they'd revert. And that's another key point that you can address. So it's important to remember that people with substance use disorders can quit smoking. And there are a lot of things that you can do as treatment providers to help make that effective. All right, next one, fact or myth, smoking affects all communities equally. This is a myth. Smoking does not affect all communities equally. There are certain communities in this country and in Wisconsin that face much higher smoking rates and much higher rates of death related to their smoking, specifically Native Americans. It's not on this slide, but the disparity between African American smoking rates and white smoking rates in our state is the greatest disparity in the entire country. So that's definitely something we have to address. People with less education, less income, people who are uninsured or on Medicaid, people with a disability, people who identify as LGBTQI, and people with serious psychological distress. All of those have significantly higher smoking rates. Partly it's related to the aggressive marketing of menthol cigarettes that exacerbates disparities, right? We have people, if you go to Milwaukee, you will see so many ads. Almost all of them in inner city Milwaukee are menthol ads. And if you go to more affluent neighborhoods, you don't see nearly as many cigarette ads, if any. And this aggressive marketing makes it easier to get started with smoking, lots of cues, and makes it harder to quit. And there's also the targeted advertisement and sponsorship, right? Tobacco industries are very aware of who they have to target. And specifically, it tends to be Black, Brown, and LGBTQ communities. And they sponsor concerts, they sponsor traditionally Black venues, they sponsor pride events, all of it, again, to really keep certain communities' smoking levels high. Quitting smoking leads people to drink more. This would definitely be a concern if you're a substance use treatment provider. So is that a fact or a myth? It's a myth. Quitting smoking does not lead people to drink more. In fact, what happens is we see that alcohol dependent smokers say that when they smell cigarettes, they actually have stronger urges to drink. And alcohol increases the time that people spend smoking because it's so rewarding. The way the brain is wired, when you start using one product and you've over time used consistently both products together, one is a cue for the other. And as I always say, when people are looking to quit smoking, alcohol lowers inhibitions and doesn't, and other drugs as well, and impairs the ability to make good decisions and vice versa. Nicotine offsets the sleep-inducing effects of alcohol, which is sort of, right? People like that. They're getting a little sleepy, they have a cigarette, and it's a pick-me-up. And again, all of this is based on the neuronal, the things that have changed within the brain at the neuron level when people consistently co-use nicotine and alcohol. Fact or myth? Quitting smoking can reduce the risk of relapse to other substances. Wouldn't that be fantastic if you had another tool that you could share with your clients, something to help them prevent relapse? So is it a fact or a myth? It's a fact. Quitting smoking actually does reduce the risk of relapse to other substances. We know that smoking is related to relapse to both substances. And the more that you smoke, so smoking maybe one or two is less risky. If you're back to a full half pack or pack a day habit, then there's a greater likelihood that you're going to relapse and that you'll do it more quickly. But smoking cessation during substance use treatment actually enhances long-term sobriety. The abstinence rates are actually almost 25% greater if somebody in substance use treatment is given smoking cessation treatment. And that's abstinence from the substance of interest. In fact, it's not even short term. It's not just if you're given smoking cessation treatment while you're in treatment for other substances, that it's not even just the initial sobriety, it's extended. This effect, where people who quit smoking during alcohol use treatment, they were 2 or 3 times more likely to be sober 9 years later. So this is an extended effect that we can see with people. And right now, there are no data that suggests that increased use of people increase their use of other substances after they quit smoking or while they're trying to quit smoking. So again, right, it would be a concern if you thought that helping someone quit smoking would actually put them at risk, when in fact, it actually promotes sobriety. Next question, smoking can increase stress. And that may seem odd, right? That's a fact. Smoking, in fact, does increase stress. And it does seem odd, right? Because smokers will tell you, well, I went out and I had a cigarette and I relaxed. But that doesn't make sense because smoking is as a stimulant. It increases the blood pressure and the heart rate. It makes the muscles more tense. But what it also does is it helps someone perhaps get out of a situation that's stressful, take a break, take some deep breaths as they drag off of a cigarette, get a little bit of a buzz, get a little bit of an affective boost perhaps. And so all of those things combine to help people think that actually smoking is a stress reducer. But actually smoking is a new source of stress, because when someone's dependent on nicotine, that's going to cause stress, right? They're going to have withdrawal symptoms. They're going to have cravings. They're going to be anxious about whether they have enough cigarettes to get through the night. And so that in itself creates its own source of stress. And if you can take that additional piece of stress away while someone's in treatment for a substance use disorder, that might be even more helpful in helping them maintain sobriety. And another key issue here is that most people learn how to start smoking in adolescence. And when I talk to smokers, what I tell them is that means you've never had an adult emotion, dealt with a challenge, a celebration, or what have you, without nicotine bathing your brain. And so you have to learn new coping strategies and other ways to deal with stress that don't include cigarettes, because in many respects, that's not the best coping strategy there is. There are far more effective coping strategies that I'm sure you've taught your clients that you work with than just smoking a cigarette. All right, next one, fact or myth. Long-term mental health is actually improved by quitting smoking. Is that a fact or a myth? It is a fact. And long-term mental health is improved by quitting smoking. Partially, it's because some of those psychiatric symptoms that are related to withdrawal, anxiety, anger, and depressed mood, once somebody gets through the initial part of the cessation, those symptoms abate. They really do ameliorate and people can feel better. But we've seen in our data and that of others that in as little as 6 weeks, we see reduced depression, reduced anxiety, reduced stress, improved mood, and improved quality of life. So while there was even one study that showed that when someone's inpatient, that in-person treatment for substance use, when people quit smoking, they actually saw the same improvement in mental distress and quality of life as the people in treatment who were non-smokers. So really, it's this idea that you could even level the playing field. If somebody who's smoking has additional stress related to that, if they can quit during treatment, they've actually leveled the playing field a bit, which is, again, another strategy that can help them be successful. All right, fact or myth. Helping someone quit takes a lot of time. Fact, that is a myth. The fact is, helping someone quit doesn't take a lot of time. Data shows that even 3 minutes of an intervention can help increase someone's chances of being quit. Ideally, what we're looking at is not hours and hours and days, about 4 sessions, 15 to 20 minutes each. That seems to be the most effective. But one of the other key pieces, right, is making sure that you're treating smoking as a key part of recovery so that you're addressing this issue that the substances cue each other. Fact or myth, there are no effective treatments to help someone quit smoking. Hopefully everyone knew that that was a myth. There are many effective treatments to help someone quit smoking, and we'll talk more about those in a minute. I tend to think about this as sort of a 1-2 punch. There are lots of counseling interventions, different strategies that you already probably use in substance use treatment related to skill building and support, and all of those are effective to help someone quit smoking. Then there are evidence-based medications, and these medications double or triple someone's chances of being successful. And when you put those two things together, the counseling, the medication, that's when they're most effective. Okay, so we explored a bunch of different facts and myths about smoking. Now let's talk about some of the roadblocks to integrating treatment into substance use settings and why it's important that we overcome those roadblocks. Roadblock number 1, tobacco has a historic role in recovery. And I think we can all acknowledge that. A lot of people actually start smoking while they were in recovery, right? It was part of the socialization. People took a smoke break. Everyone went outside or went into a different room or what have you. In fact, smoke breaks for a long time in inpatient settings were used as rewards and punishments. That was true of inpatient psychiatric as well as inpatient substance use treatment. And so we had a whole token economy based on cigarettes. And that was really problematic. And so, as I said before, when people are introduced to tobacco as part of recovery, it creates a serious problem. So how are we now dealing with that as recovery provider experts? And some people think, well, it's a safer option, right? It's not intoxicating. It's a drug, but you're not intoxicating. It's not fatal immediately in terms of overdose, but it is, 7 of the 10 people that use it will die from it. And it's, we're just using it for coping mechanisms to deal with stress, urges, negative emotions that are related to, our other substance use treatment. And like I said, recovery left them, unfortunately, if they started smoking, with an addiction that'll kill them, because 2 out of 3 smokers are going to die from smoking related disease. Smoking is a right, or it's a personal choice. I know that as treatment providers, you are very focused on trying to make sure that your clients feel that they are empowered to take control of their lives, empowered over their addictions. And using any substance is a personal choice, but so is quitting, right? I already showed you the data that most people in substance use treatment want to quit smoking. And so we want to make sure that we're offering them that opportunity, that we don't take away a patient or client's right to choose to quit. So it's not about being a nanny state and insisting that people quit. It's making sure that they have the right to choose a healthy option, if that is something that they would like to do. Treating smoking is not part of recovery. That's not something we've ever done. We specialize in lots of different things. People aren't here to quit smoking. They just want help with other addictions. But as I've shown in the earlier data, when you help someone quit smoking, you're actually helping them stay clean and sober from all of the substances. There are neurochemical as well as behavior links between smoking and other substances. And so helping them quit smoking is actually giving them one more tool that they can use to stay clean and sober. So it's important then that you actually start this conversation in a way that your patients or your clients can understand that you're supporting their full recovery. I'm not just focused on your, one substance that's the court mandated treatment or anything else. I want your full recovery. You're here to make some major changes to become healthier and overcome addiction. That means your addiction to tobacco as well. And I'm here to help you with all of it, making sure that they don't feel like they're alone when they're tackling their tobacco dependence. Roadblock 4, someone on my clinical team, or maybe me, smokes, right? There's a history of recovery that's pretty common among substance use treatment providers and counselors. And so how do I deal with that? If I'm smoking or someone on my team smokes, how do I now talk about helping someone quit smoking? A common strategy, I think, for many providers is some self-disclosure about strategies that have been used in the past or helpful or hard times and what people have done with those. And what I would suggest is you could use that same kind of honesty when you're addressing smoking. It's not hypocrisy if you're able to be honest about how hard it is to quit smoking and your desire to help. Quitting smoking is really hard, and I'm still working on it. But that doesn't mean I can't help you. It doesn't mean I don't have strategies and suggestions and ideas that you can use. Or something along the lines of, I don't want you to be stuck in the same place I'm in. I'm not going to ignore your smoking. Just because I haven't been able to get past this addiction doesn't mean you can't. And the same would be true if you're dealing with someone on your team. Just because someone on the team smokes doesn't mean that person isn't still trying to quit. And it doesn't mean we're not all going to do our best to help you. I don't feel comfortable addressing tobacco. Again, it might be part of that, how it's existed in your personal treatment setting or in the training that you had. And perhaps you just haven't had a lot of training in how to address tobacco. And that's okay. But fortunately, there's a lot of treatment opportunities, and we're going to be talking about some of those here. And the other important piece is a lot of the skills that you already have, that you use with all of your other clients are going to be really relevant here. Okay, so we're talking about motivational interventions, helping people understand why would it be a good idea to quit smoking. And we'll talk more about some of those interventions in a minute. Some cognitive behavioral therapy skills, helping people develop healthy coping skills. You're already doing that as part of your treatment. Learning how to avoid cues and triggers. Again, we're talking about just expanding it beyond the substance of focus to also include the cues and triggers for smoking. And alternate reinforcers. This is a really big one. And I feel like this has also come into play a lot, and it comes into play a lot in behavioral health and especially in substance use treatment. And that is, smoking's the only good thing left in my life. It's the best thing. It's the most enjoyable thing in my life. And people will tell me that. And my typical response is, I find that unacceptable. I find it absolutely unacceptable that the best thing in your life is going to kill you. And so I want to work with you and make sure that we can develop lots of things in your life that are better than smoking. That, I think, is a really important and powerful message to send to the people that you're working with. And again, most people are open to it. So even though you're not comfortable addressing it, people are wanting to talk about it. They're wanting to change their smoking. And again, you are expert, and you can develop more expertise and more experience in helping people with their tobacco dependence. Number 6, we're not going to be paid for this. So why do we spend our time? And this is always a challenge, right? You guys have such limited time and a lot of work to do in that time. But treating tobacco dependence is actually highly cost effective. When we look at estimates of cost effectiveness, they set as the gold standard mammograms, right? Mammograms are $50,000 for each what they call quality life year adjusted, saved. So every time, that's sort of the standard set is $50,000 per quality, and that's breast cancer. Smoking cessation treatment is like $2,000 per quality. And so it is so incredibly cost effective. Finally, providers and payers are starting to take note. And so right now, Medicaid and Badger Care cover all the smoking cessation medications, and they cover counseling. There are different documentations that can lead to billing. And there's actually going to be a link at the end of this presentation that you'll be able to access on the recording that will show you all of the different links for all of the different billing codes. So you can bill for it, and it's important to bill for it because it's an incredibly cost-effective treatment. Okay, so let's talk about what kind of things you might bill for. What are some treatments that you want to be able to provide for the people in your agency who are smoking and interested in quitting, or not interested in quitting, I should say. The treatments I'm going to talk about are based on the United States Public Health Service guideline that was published in 2008. Now, all 3 of the guidelines, the past and the current update, were all developed actually here at the University of Wisconsin under the guidance of Dr. Mike Fiore, who is the director of our center. And what we did, I served as the senior scientist on the guideline update. And what we did is we looked at literature from 1975, the first smoking treatment literature, all the way through 2007. That was almost 9,000 articles. We coded data, we did meta-analyses to come up with the best ways to help people quit smoking. And as part of this, we developed this algorithm that we call the 5 A's. So the ask, advise, assess, assist, and arrange follow-up. I'm going to take these one by one. So let's start with ask. This is really important. And this is documenting. This is right. This is part of what the new Chapter 75 says. You have to ask about whether people are using tobacco. So where is it in your intake procedure? Where are you going to actually document this in your intake form? And you want to ask, have you smoked cigarettes in the last month? If somebody says yes, you need to act. Anybody that's smoking needs to have additional steps taken. But in addition to smoking, now there are so many different nicotine and tobacco products available. You might want to make sure that you're also asking about other products. Cigars, little cigars, cigarillos. Some little cigars look exactly like cigarettes, but they're actually cheaper because they don't get taxed as much. And so people may think that they're not, it's not so bad because it's a cigar and it's a natural wrapper, which is what makes something a cigar, but that's not the case. You want to think about electronic cigarettes, including jewels, disposables, mods, pod systems, all sorts of things. There's hookah, there's chew and smokeless. You want to know about all the tobacco products people are using. And one of the key benefits of having the question about smoking or question about tobacco use built into your system is it increases equity. We have shown that when everybody gets asked the question, then everybody starts into the treatment pipeline, and we don't end up with certain people getting offered treatment and other people not getting offered treatment, which enhances equity. Once you've assessed anybody that says, yes, I've used tobacco in the last 30 days, the next step is clear, strong, personalized advice to quit. right? You're not going to ask them if they want to quit first. You're going to let them know that it's important. Wow, I got to tell you, okay, good to know. Thanks for letting me know about your smoking. But quitting smoking can actually help your recovery. And I highly recommend that we add that to your treatment plan. Or something along the lines of, I know you're here to address your other addictions, but this is a great time to address your tobacco dependence too. I'm ready to help you with all of it, right? Because we really want you to be able to quit so that you can maintain your sobriety and not present an additional risk for relapse. And even this brief advice can actually increase someone's chances of quitting smoking. So once you've asked them and you've given the advice, then you can assess, is this person ready to change their tobacco use as part of their substance use treatment? Would you be interested in learning about some treatment options about making changes and gaining some control over your smoking? Are you interested in talking today about your smoking? It's something I can certainly help you with, and figure out what they're interested in. If someone says, yes, wow, if quitting smoking is going to help me with my sobriety, then yes, let's do it. So then what do I do? What should my treatment plan include? Well, like I said, it's that 1-2 punch: counseling, and the more you can do, the better, but even 3 minutes helps, and the medications. And we'll talk about those in a minute. But ideally, you want to make sure that you're giving both the counseling and the medications to all the smokers in your treatment setting that want to quit. So let's talk about the counseling. And again, some of these are going to sound familiar. They're strategies you probably already use. First one is setting the quit date. That means no smoking, not even a puff after you wake up. A lot of people, their downfall is, right? And you've heard this: just one drink, just one toke, just one puff off a cigarette, and you can end up right back in your regular smoking pattern. You also want to make sure that you're getting rid of all your tobacco products, the same way you would with any other substance. But this doesn't mean just throwing them in the trash or I had one person I worked with dunk it in a toilet and then put it in the trash, because that person fished them out of the toilet, put them in the fished them out of the garbage, put them in the microwave, dried them off, and smoked them. So they have to completely be gone. And as with everything else, all the cues, the lighters, the ashtrays, everything. Next, I would suggest thinking about learning from past quit attempts. You've tried to quit before, most smokers have. What's worked? What's been helpful for you? Let's build on that. And what's led to relapse? Let's make a plan for that. So identifying some real concrete things that we want to focus on doing, and some things that we want to have a plan for so they don't trip us up again. And then again, planning ahead, anticipating the challenges and thinking about ways to cope. So for example, if somebody says, well, the last time I tried to quit smoking, I did okay. I made it like 2 months, but then I got in a fight with my supervisor and it led to relapse. Okay, so I figured that out when I asked about past quit attempts. So how are you going to deal with stress? How are you going to handle it if your supervisor comes down on you again? What are you going to do differently? It could be something like, well, I'm going to chew some gum, or I'm going to call my friend, or I'm going to ask to take a break and walk around the block. Whatever it is, that's going to be a concrete strategy so that it addresses their, whatever it was that triggered the relapse last time. Again, these are strategies that you already know, but they are helpful. And they work just as well with people who are quitting smoking. So craving and withdrawal symptoms, triggers and cues, other people who smoke, including at home. So this is another challenge. Is your home smoke free? And if it is, great. Where do people smoke at your house outside? And is there a way that you can keep them out of sight? So that people are smoking, not maybe on the patio, but maybe they go around the corner so that you don't see them. Or if they normally smoke out on the patio, maybe they go out the front door and smoke out there instead. And if this home is not smoke free, then can you at least make a room smoke free so that there's no cigarettes, there's no ashtrays, there's nothing in the person's immediate view that would trigger cravings to smoke. And finally, one of the things we talk about when we were working with smokers to help them quit is avoiding the other alcohol and substance use. It's that same thing about getting in the way, and how using one product can cause cravings and lack of advanced thinking, right? It's going to impair executive processes. So it really leads to relapse in a way that we're trying to avoid. So those are sort of our general things that we talk about when we're trying to help someone quit smoking. But when you're talking about quitting smoking during recovery, I think there's some additional things that you could talk about. recognizing the challenges of recovery, and that quitting smoking, again, is going to increase the odds that somebody's hard work is going to pay off and they're going to be successful. Gosh, why do I have to quit smoking everything all at once? That seems like such a challenge. Can't I just do one at a time? You can if that's your choice. But I tell you right now, if you put all the work right now into quitting everything, you're actually going to reduce your risk of relapse on everything. So that's, and I'm here to support you while you do that. And that's why we're suggesting doing it all at once. And then really helping people understand how their smoking is related to their substance use. Do you use them together? Is this somebody who rolls a lot of blunts? Is this somebody who is drinking and smoking always at the same time? Do you find that you're smoking when you can't use something else? If you are waiting to score or you can't, use whatever, are you smoking to help you manage the withdrawal from that? And then again, it just illustrates how interwoven these substance use regimes can be, and that people have these patterns of behavior that really twine together tobacco use and other substance uses. And that's where helping them understand that can help you target what you need to do to avoid those situations. Also, people that have been in recovery sometimes for one substance, we help them say, well, those substances worked in the past, those skills worked in the past for other substances. Could you use them now? What would you use now? And that same is true for tobacco. How could we apply what you've already learned in this program or you learned last time you went through a program to helping you also quit smoking? And then what are the skills needed to navigate recovery as a non-smoker? Again, finding other reinforcers, finding other things that help you feel good about your life. Meaning, we tend to call those sometimes we'll talk about pleasurable activities, and sometimes when you're in recovery or you're dealing with serious mental health issues, there's not a lot of pleasure in life. And so we talk about meaningful activities. What are some other things you do that are meaningful to you? You might not always enjoy them, but they feel good. They're things you like, they're meaningful. And then also talking about ways to socialize at meetings or in group settings, so that if you are going to some sort of AA group or NA group, you're trying to pick ones that are smoke-free, or you're figuring out a way to stay inside if everybody else is going out for a smoke break. And I really do think it's helpful for folks who are quitting smoking to have something concrete. So this is something that we developed at our center. We just call it My Quit Plan. It has their quit date, some things to think about getting ready, things to remember. These are things to either avoid or have a plan for, the medications they're going to use, and then how to get support. And again, the link for this will be at the end of the presentation. The other nice thing about having something concrete like this is they can put it up. They can put it up on their, on their bathroom mirror. They can put it on the refrigerator. It helps them remember the strategies. I would also suggest that you use some supplements to counseling. So people can call 1-800-QUIT-NOW in Wisconsin. They get free coaching and support. They can also get 2 weeks of free NRT. And you can actually provide direct referrals. So I don't know if your clinical site is set up to do this, but we here at our center, we have outreach professionals, and I'll show you in a second, or I'll show you at the end of the talk who they are and where they are, but they can come and help you set up and create either a fax referral plan to the Quit line, or they can help you with an e-referral, even through the EHR. And so the Quit line is a fantastic resource for people to help promote smoking cessation counseling. They'll do a proactive call, and then people can call them as much as they need. There are also websites that are really effective. So this is the website for smokefree.gov, and it helps you, again, create that concrete quit plan. It'll show you how much money you've saved after you've quit. It's got specific modules for people who are pregnant, for people dealing with depression, and all sorts of important advice, information, things like that. And so these are things, again, if you don't have a ton of time to address tobacco, these are other resources that you can use in connections to other professionals that can help your clients with their smoking. So I want to talk for just a minute about the medications. There's 7 FDA-approved medications, and they include 5 different nicotine replacements. So that's the patch, the gum or the lozenge and the mini lozenge, the gum, the inhaler, and the nasal spray. And those 2 are really prescription only at this point. And then the most effective, which is combining the patch with an ad lib. So this is the patch together with either the gum or the lozenge or the mini lozenge. The patch provides that steady state of nicotine and helps reduce the cravings and withdrawal. And then you can use the ad lib when you're having an extra craving and you need a little more nicotine, or in a situation when you would typically smoke and you need a behavioral response. And so that has really been shown to be more effective than a single nicotine replacement. And then there are two pills. There's varenicline and bupropion. Varenicline is the most effective at this point. So it's also known as Chantix. It's a pill that you take twice a day. You start it for the week before you quit. And then it's in the bloodstream in sufficient doses to really do the best job of reducing withdrawal and also reducing the positive reward from cigarettes. That's kind of the nice part about varenicline is cigarettes aren't quite as rewarding when you're taking varenicline. What I want to make sure to note too is people are real concerned about using Chantix. There was a big health scare about whether or not Chantix was safe for people. It had a black box warning from the FDA for a while, but they have done this enormous study. It's called the Eagles study. Thousands and thousands of smokers with and without behavioral health conditions in multiple countries. And they found actually that varenicline is just as safe and doesn't cause any more suicidality or mental health concerns than did any of the other smoking cessation interventions for either the population with behavioral health concerns or the population without behavioral health concerns. It is a prescription medication, so you'd need a physician or prescriber in your system to help with that, but it's incredibly effective. So what if you've documented that the person is a smoker, you've given the clear personalized advice to quit, you've said, hey, it's really important to help you quit smoking and I'm here. Are you interested in talking about it? And the person says, nope, right now I can only focus on my drinking or whatever. You're not done. It doesn't actually let you off the hook. There are motivational interventions that our analyses from as part of the guidelines showed actually help increase the likelihood that people were going to quit. And again, this is stuff, using a motivational interviewing approach, developing some developing discrepancies through decisional balance exercises. Whenever I talk to smokers and we ask, what do you like about smoking? They always sort of take a step back, like, well, why are you asking me that? Well, because there's reasons that you're still doing it. So what is it that you like? But then also understanding what you don't like about smoking. What would you enjoy about being able to be smoke-free? And what would be hard if you tried to quit? What are the roadblocks? You want to make sure that they understand how quitting smoking is relevant to their recovery, that it can really promote cessation, that it can promote sustained abstinence from all substances of abuse. You want to talk about those potential rewards for quitting. And then what are those roadblocks? What's getting in the way of them trying to quit? And then once you've, a motivational intervention, but then asking them to take a next step. Okay, you're not ready to quit now, and that's fine. We will work around that. But would you be willing to take a next step? What do you think about trying to cut down or not smoking in certain places like your car or in your house? What do you think about waiting the first cigarette until after you've had some coffee or until after you've gotten dressed for the day? What do you think about using some nicotine replacement product either in place of a cigarette, substituting a piece of gum for a cigarette, or just wearing a patch to see if it helps you cut down on the number of cigarettes you smoke per day and reduces your urges? FDA has said it's entirely safe to use nicotine replacement products while you're still smoking. There was a health concern a long time ago when the patch first came on the market, but that's really been shown to not be an issue. And again, making that change plan. Again, having something concrete they could write down. Things I like about smoking, things I might want to, reasons I might want to quit, and what's getting in the way. What are some things I could do about maybe some of those roadblocks? Is there something that I can do about that? What small changes could I make? And then when I am ready to quit, how would I go about doing it? And again, the link for this will be at the end of the presentation. And finally, arranging follow-up, right? Tobacco dependence, like any other addiction, is a chronic relapsing condition. And as with any other substance use disorder, ongoing support is key. So multiple contacts are better than single brief interventions. And so maybe it's something where you help set a quit date, they are able to do that, and it's just a little piece of your check-in as you're working on all of the other substances or all of the other treatment goals. So again, this is the 5 A's algorithm. The the new chapter 75, make sure that you are documenting how you're asking about current tobacco use, and ideally in a thorough assessment would be great. And they have to have a written policy now about how you're doing this. And if you have a standardized policy, this really also helps with health equity. Then you want to make sure they've got clear, strong, personalized advice to quit. You want to assess what are their treatment goals? What are they willing to do at this point with respect to their smoking? Remembering, of course, that almost half of people in substance use treatment want to quit smoking. If they're ready to quit, it's the 1-2, it's the counseling and the medication together, and then also having some supplements, perhaps the quit line or a referral to the websites. If they're not ready to quit, what kind of motivational interventions are you doing? And then what type of next steps might they take? Could they cut down? Could they use an NRT? Could they make certain places smoke-free? And finally, arranging follow-up. It's a chronic disease. It's nobody's failure. It's just something we have to keep trying with. So some key takeaways from everything I've covered today. Tobacco treatment is an important part of recovery, and we have finally moved to a place where it is actually now instituted in public policy in these, in these actual rules. And so this is actually an exciting step. This is a point where public health and the bureaucracy are coming together to really serve the health of the public as best they can. We're recognizing that most people who use tobacco are interested in changing and possibly quitting, and they can do that. They can do it successfully, even if they have a behavioral health condition, and they can be most successful with your support, because you, behavioral health and substance use treatment providers, have the skills and the focus and the commitment to helping provide tobacco dependence treatment. When you can provide counseling and medication for smoking cessation within the context of all of the other substance use treatment you're providing, you're actually giving people additional tools to help them maintain their sobriety. And finally, I want to note that these are our different outreach specialists. Sarah Thompson is in the Northeast region, and Susan Lunson in the Northwestern region, Amy Scora in the Southern, and Ali Gorilla in the Southeastern. These are folks you can reach out to. They can help with additional training and technical support. They can help get you connected if you want a referral, either to be able to do e-referrals or fax referrals to the quit line. They are outstanding resources. Each and every one of them is committed to this work. I want to remind you that this was just the first of a 2-part webinar. The next one coming up is integrating tobacco-free environment policies in substance use treatment settings. And you can see that'll be on September 16th. And with that, I'm happy to answer any questions that people have. Thank you.
All right, thank you, Megan. We have been trying to answer questions that have come up in the chat, which have been great. So it doesn't look like there's any specifically for you right now, but if anybody has questions about any of the content that we've added so far, let us know. It looks like there was just a question about the PowerPoint today. It is going to be recorded. And so both the recording and the slides will be sent out in an email probably next week at some point. And then also the link to the webinar as well as the slides will be available on the DHS 75 revision page. And then it will also be available on helpusquit.org. So we will make sure that you have access to both the slides and the recording.
So I am just scrolling through some of the questions, and I did see the question about the handouts regarding ambivalence about quitting smoking. As I said, we have the, we have the one handout that I showed you about thinking about your smoking, thinking about making a change. If there was something that I'm not sure I'm aware of anything else that's a hard copy, but definitely perhaps creating something for your organization. And this might be something that the outreach folks can help with, that talks about, quitting smoking is an important part of recovery in our system, within our clinic, within our treatment center. This is important to us too. And here are all the reasons why. And then, maybe adding a little blurb at the bottom about why do you like to smoke and why would quitting be helpful for you? I could see that developing something like that, a handout that people could refer to, would be helpful. And I don't know of any that we have at this point.
One other thing, so there's the regional outreach specialists were mentioned, and then Megan just mentioned them again. Sarah is going to be putting up the link to the regional outreach specialist page. That Megan, will you go back one side to
Yes.
the ROS, or maybe it was a couple, to the ROS map? Yeah. So you can see here on this map, there's 4 outreach specialists, as Megan said. So depending on your county, that's who you would contact. And Sarah just provided the link to this map. So if your county falls in whatever area, the outreach specialists regularly work with facilities throughout the state on this topic. So feel free to contact them, and they do great work. So there was a question, will it be required to document staff training in this area? Is there any completion certificate for this program? These are great questions. To my knowledge, there's no staff training requirement for this, but the DHS 75 requirement, does require assessing for tobacco use. So, this is obviously a great training for your staff to help them understand how to do that. This is a great question though to put in the DHS 75 revision website page. So I don't know if you can put that in there, but I'm sure you're all familiar with that. And then there's a question box at the end. So I encourage you to put that question in that box, because you're probably not the only one to have that question. And then DHS can answer that for you. And then, is there any completion certificate for this? We don't have a certificate completion, but if you've completed it and you need something from us, we're happy to get that for you. So feel free to contact us directly if you need something. And then Megan just put the revision implementation webpage in the chat. So like I said, any questions specific to the DHS 75 rule, we've been asked by the Division of Care and Treatment Services to encourage everyone to put those questions in that question and answer, or in that question box at the end.
And I guess one question I would have, thinking about all the facts and myths we went through, or the roadblocks that we went through, we tried to be as comprehensive as we could, but are there facts or myths that people are still wondering about? Or are there roadblocks that we didn't touch on that need to be addressed? It would be great if you wanted to share those with us. All right, I guess we were pretty comprehensive. And I'm sure there are specific issues that are related to your specific treatment site. And, there always are. There are always different challenges. I would just really hope that, I'm sure administratively, this feels like one more thing that has to be done and one more I that has to be dotted. But as I said before, this is actually the culmination of years of work by healthcare professionals. I think David McMaster is on this call. I thought I saw him earlier. So thank you, Mac, for your leadership on all of this, to really try to address what is a critical public health need, not just the treatment of substance use dependence, but smoking cessation. It's sometimes easy to overlook when all of the other substances cause such enormous life disruption and pain and harm and damage. It tends to be sort of the quiet drug that tags along that nobody thinks about when they think about substance use dependence. But it is, as I said before, and as I showed you before, it is the most fatal that we will address. All right, I don't think there looks like there are any other questions. But I hope this has been helpful. It may have been new things, it may have been a review of things you already know, but I really appreciate your attention. And I wish you all the best in implementing Chapter 75.